Okay, Christine, do we have any questions this time?
Yeah, we have some questions this time.
Oh, thank you.
Okay, so there are two questions for you, Professor Kamaka. So the first one is for lumbar plexus block. Which view is performed without much complication among the three?
I think, as I demonstrated to you, that the shamrock view gives you a good view of not only the sonar anatomy, but also the plexus nerves and the nerve root and visualization of the needle. What view causes least complication? I think today there are no published data to say which view produces the least complications. I think the prudent way to be would be to have a good understanding of the anatomy, be able to visualize the needle, and then perform the procedure when it is really indicated. So these are some key points you need to keep in mind, and use the view that gives you the best visualization of not only the needle, but also the anatomy.
Thank you. And one attendee would like to know how much local anesthetic do you inject into the lumbar plexus block for surgical anesthesia?
For surgical anesthesia, we use a maximum of 25 mils in our community. So most of our population in Hong Kong weigh about 60, 65 kilos, if you may, is the average weight. So about 20-25 mils is a good volume of a surgical concentration of, say, 0.5% ropivacaine, levobupivacaine. My advice to you would be to add some epinephrine to it, because that may give you a clue as an intravascular marker. Not that you want it to prolong the duration, but just as an intravascular marker, as that area is fraught with a lot of vessels. So intravascular injection is not uncommon and has been described in the literature. So also use incrementally small aliquots of injection between 3 to 4 ml. Yes.
And is it possible to introduce a catheter?
Yes, it is definitely possible to place a catheter and use it for post-op analgesia. But my personal experience is, although it is possible to place a catheter and have a good primary block, that means when you give a large volume with your initial catheter placement, you'll get a very effective block. But as your infusion rates are much lower, you run between 6, 7, 8 mils, maybe 0.1 mils per kilo. In that situation, you may have some recession of the whole block. So today, there are no data to say what volume produces continuous blockade of the entire plexus. So I hope you're understanding what I'm saying is that with the infusion rates you use in clinical practice, you may not be able to block the entire plexus. So I think there are data which shows that clinical efficacy is better if you place a catheter and use intermittent bolus injections, or have a provision in your infusion system that can deliver intermittent boluses of local anesthetic. So if you give a primary injection of 10-20 ml of concentration of surgical concentration, then use a lower concentration bolus, but of a larger volume, and then use rescue as a PCA, patient control rescue of a smaller volume. Then you'll get a better efficacy.
Okay, thank you, Professor Kamaka. So here are some questions for Dr. Lin. So the first question is, what is the position of the hip while performing prudential nerve block? Is it in internal or external rotation?
Okay, it depends on which level you are injecting. If you get the information from physical finding that pinpoint your pain, it's a little bit higher, then my first shot will be in the interligamentous space, i.e. it's at the ischial spine level. So it doesn't matter if you are doing the internal or external rotation. But if you are aiming a little bit lower, you are targeting the Alka canal, then I will do some internal rotation to pull out the obturator internus muscle to see the internal pudendal artery dives in, and then I inject on top without hitting the artery for the Alka canal hydrodissection. I think Stanley can give us some comments on that.
I totally agree with, if we are going to just doing between the sacral tuberous ligament and sacral spinous ligament, when the pudendal nerves just branch out from the sacral plexus and then dive into the pelvis, and it doesn't matter which position you put your legs. But if you want to do an Alcock's canal between, especially you're trying to expose the pudendal nerve better, it's better to internally rotate the hip and then to have the obturator externus more exposed. And it is you have a longer length of this pudendal nerve underneath your view. So it's that will give you a better outcome for this pudendal nerve hydrodissection. But of course, you have to be very careful about the pudendal artery, which going together with pudendal nerve. So my advice is you have to keep the power Doppler view. Better to have a dual view at the same time, and then keep hydrodissecting to push away the nerve and also the arteries. So that's my humble view. I agree with you, Patrick.
Thank you. So another question for Dr. Lin would be, can pudendal nerve block at the level of the ischial spine help entrapment site other than the Alcock canal?
It's an excellent question, because the pathogenesis of pudendal nerve entrapment comes everywhere ever since from S2, 3, 4, foramina and the intrapelvis, and also the junction outside, going out and then curves in back to the pelvis and the Alcock canal and the even very distal part. So it depends on which level you are aiming. Yeah, so most of the entrapment part, my first shot will be ischial spine level, but next I will decide my injection by physical findings. Sometimes it's very high, then I will do S2, S3 transforaminal hydrodissection for the sacral roots.
Thank you, Dr. Lin. So as for Dr. Lam, so there is one question among the audience. They would like to know, can we do ultrasound cervical spine in a sitting position?
My humble advice is, when you do the scanning, you can do that sitting as well. I do that all the time, and especially I want to do the dynamic test and ask the patient to move the neck and then to see the structures. But if you want to do an intervention, to do any block, any hydrodissection, any needling techniques, I advise you to have the patient lying, either the supine, side lying, or lying prone, because I think vasovagal attack is very common when you do whatever interventions, especially you're trying to do an intervention into the cervical spine, to have the patient lying down instead of sitting. But dynamic scanning for diagnosis, you can do that sitting or side lying or even moving the neck. So that's my advice. Thank you for the question.
Thank you. So I think that's all for now.
Okay, I think I just went through another question from an anonymous attendee saying, is it necessary to teach lumbar plexus block? For example, the curriculum for fellows in regional anesthesia. It's a very valid question, and I think I take this opportunity and I understand your feelings, because lumbar plexus block is described as an advanced block. But is it really that advanced? Not really, because at a time when ultrasound imaging was not as clear as I would say, but today we have abilities or different imaging planes that allow you very clear visualization of the paravertebral anatomy, as well as the lumbar plexus, as well as the foraminal area. So I think guiding a needle to that area is not as complicated as one would have thought. But I think the risk associated with it in terms of intravascular injection or injuring a vessel is surely there. But whenever you insert a needle in a vascular area, does it always puncture it? I think the answer is no. But do you rely on your luck? I think the answer should be no. So at the same time, clinically, there are very few good evidence-based indications for lumbar plexus block. You can use the same clinical efficacy or produce the same clinical efficacy maybe with the femoral nerve block or with a ductal canal block and so on and so forth. But if you are an anesthesiologist and you specialize in regional anesthesia, I think it is imperative you should learn to do it, because there are times when you need to anesthetize the entire extremity where a femoral nerve may not be effective. You want to do, say, for instance, an amputation, above knee amputation, quite high up disarticulation, then the number of injections that you need to do increases exponentially if you are going to do selective injection, where a single injection at the lumbar plexus would suffice for you to cover the entire plexus of the lumbar plexus of nerves. So I think in that respect, I still teach my fellows, but I always tell them that this is not something you need to do every day. You need to do it when you need to, really your chips are down and you need to have, you need to do it in a patient that where there are no other options, when then your risk benefits are acceptable. So I think I would put this as my final answer to this anonymous attendee. Okay, I think with this session, I think I would like to take this opportunity to first thank Christine. You've spent a lot of time here filtering all this. Thank you for joining us. Patrick, thank you. And despite the church behind you, it looks beautiful, and I'm sure Taiwan is a beautiful place. Look forward to being there soon. And I wish you speedy recovery. You're looking very good. Hopefully you recover well. For you, Stanley, you're a champion, and keep doing the good work you do. And I'm sure our attendees, and I bet many of you who are listening in from far and wide, will be very impressed with the knowledge that Dr. Stanley has exhibited, and he is truly a good champion. So remember, you cannot learn what he taught you or what we taught you in 3 hours or 4 hours that you spent here. But the fact that you were here this evening or this morning or this afternoon is we have hopefully stimulated you to learn more about this. All these videos are being recorded. They will be posted at the end of this webinar series. So don't you worry, you don't need to record them. We will record them, process them, and we will upload them for you so that you can go at the comfort of your own time, go and revisit these videos and practice them in your clinical practice, because practice makes perfect. And before we sign out, I also like to mention that next week is another exciting week for pain physicians and pain specialists. Dr. Lin will be back with us again to talk about cervicogenic headache. We have another few champions. Dr. Manfred Greer will join us from Vienna in Austria. Dr. Gulati will join us from New York to talk about peripheral nerve stimulation for the treatment of chronic pain. Dr. Greer will talk about low back pain. And we have Dr. Shibata from Japan, who will be joining us to talk about many of the fascial and all the fascial and your maxillary, mandibular, etc. nerve blocks. And he will also do a live demonstration live from Tokyo in Japan with the courtesy of Konica Minolta. So it's going to be a very exciting week of another webinar number 5. So remember, put it down in your diary and be ready with your favorite beverage in front of your computer on that day, and tell all your friends and colleagues to be there, as we are going to have a very exciting time. So with these few words, I thank all the faculty, including those Dr. Feigl and Dr. Hariharan Shankar. You've been a great help to all of us. And as we say, the issps is the venue to be if you want to learn real sonography and real ultrasound about regional anesthesia and pain medicine. See you next week, and thank you, everybody. Bye-bye for now.